Hi everyone. Morning. Welcome. We can't see you, but hopefully you can see us. This is I think the final PPA support group session for this year. It's an interactive webinar which we want to make open for your questions and hopefully some answers. I just wanted to say at the outset, thanks so much to Nikki, Emma, and the team from Rare Dementia Support, who've done a lot of the behind the scenes to make this possible, and also mediating and running things in the background. You can see them on screen. Actually, you can see them hopefully. So thanks to them, and also to my co-panelists, particularly Chris and Anna, who will be available to answer questions. Chris, I think, will be the question master. And I hope you know us all by now, but I know there are always people joining. So in case it's all new to you. So I'm Jason. I'm a neurologist and I work at the National Hospital running a clinic there for PPA and also a research program in PPA based at the Dementia Research Centre at UCL. And Chris Hardy is the senior postdoc scientist in our group who's got a particular interest in PPA, the science and the clinical translation of the science. And Anna, who many of you I think have met clinically as well, is a specialist, highly specialist speech and language therapist who will be able to comment on some of the more clinical aspects of what she does, which is a very important part of PPA, of course, as many of you realize. So I think we should devote as much time as we can to questions. The most important thing to say about the actual act of asking questions, is that it's all going to be done via Q&A, not the chat box in your Zoom. So I think the chat box is probably closed actually for you, but it's a Q&A entry point, and then Chris and team will mediate the questions and direct people to answer them. Okay, so I think we should try and kick off. So Chris, I will hand over to you and assume the role of a panelist.
Perfect. Thank you. Thanks, Jason. And good morning, everyone. And we have had some questions submitted in advance, but as Jason says, please do submit more via the Q&A box. And just to say as well, in case it's not obvious, I'm sure every one of you watching would have met with Nikki or one of her team before, but Nikki is also very kindly on our panel today and knows everything there is to know about health and social care and how to access them. So we've got representatives from neurology, science, social care, and speech and language therapy. So hopefully we've got a very good coverage amongst our panelists today. So I'll kick off with a sort of a more medical question. So Jason, I think this one's probably for you. How has there been any research into the effect or presence of seizures on aphasia in any of the progressive aphasias?
Yeah, it is. Thanks. So yes, it's an important question. So we do see seizures. They're not very common, and particularly they're not very common early on. That goes for all types of PPA really. But we do see them. We particularly tend to see them as the disease goes along. And they are usually, I mean, these are generalizations, of course, but usually relatively easy to treat. So it's unusual for people with PPA to get sort of resistant epilepsy, so with tablets. And we have one or two tablets that we like to use by preference because they have fewer potential side effects. So all tablets have side effects, but some have fewer than others. And obviously what we're trying to do is get tablets that have minimum impact on people's cognitive function. And there are particular types of seizures too. And sometimes we see, and probably this is a bit more common in logopenic aphasia because it's a type of Alzheimer's disease in most, not always, but in most people. We see muscle jerks, or what we call myoclonus, and this is on a continuum with seizures. And so the sort of more generalized seizures that are obviously seizures. We have particular tablets that are useful for that, and so that can sometimes be quite an issue, and people may be quite frightened sometimes by that and get very worried about sort of jerks and twitching movements. But in general, we really only mainly worry about big seizures, ones where someone has, either loss of consciousness or clearly altered awareness of their surroundings. And those are the ones we really try and prevent. It's not necessary really to try and treat and suppress all jerks, or muscle movements. And in fact, sometimes the only way to do that would be to keep someone very sedated. So we don't like that. So we have to strike a balance between, side effects and treatment. Sometimes seizures can be more difficult to recognize, and this is one of the reasons why we like people to be in touch with neurologists. And it's also true to say that not that we don't understand very much about seizures in PPA, and there's still quite a lot of scope for research. So I think that might have been the original thrust of the question, but actually the answer is it's still a fairly open issue in terms of understanding them, but we do have ways to manage them clinically. So if there's concern, obviously, and this goes for most things we'll discuss in the Q&A, you definitely need to discuss with your medical neurology or psychiatry team if there's concern about this.
That's perfect. Thank you, Jason. Other panelists, please feel free to sort of chime in if you'd like to add anything to any questions, but otherwise I'll move on. So the next question, I think this is probably for you, Nikki, actually. So how can we help request help in accessing health and social care services? We're really struggling to get any help at all at the moment.
Thanks, Chris. And unfortunately, it is a postcode lottery out there, and we see some areas have really good services when other areas really fail with that. The point of core of the GP is always the gatekeeper to health services, and that's often because it needs to be a GP referral to actually access the services. The GP has to request that through the health system. Some people really struggle having a relationship with their GP, and I think it's really important, if there are struggles, to actually speak to the surgery and the practice manager to explain that this is a rare dementia and there will be health and social care providers that need to be accessed through the GP. So trying to build up that good relationship with the GP is really important. Social care needs. So some needs come under the healthcare system and some come under the social care system. So it's really important for people to have a needs assessment. And I would always urge people to have a needs assessment at the earliest time possible, even if they don't feel they have any needs, because it gives a good benchmark of where they are. And also people need to have these needs assessments repeated, sometimes every 6 months. Sometimes, if things are going along quite steadily, it can last sort of a year, but when there are significant changes. And the social care needs assessment will identify what people's needs are for their everyday living activities, but also their well-being as well. But we're more than happy, whoever's put that question in, more than happy for them to contact us on the contact@raredementiasupport.org email, and we can organise a phone call or a Zoom call to help sort of address any problems that they have. Thank you.
That's perfect, Nikki. Thank you very much.
Chris,
okay,
can I just add something?
Sorry, Jason,
Sorry to cut in on you. Can I just say, because I know in a way I know we're preaching to the choir because you're all here and this is a rare dementia support meeting, but do please spread the word because I still meet people in clinic who have not heard about Nikki's team. It's a unique resource, in terms of the sort of the landscape of many diseases that people struggle with. They do not have access to anything like this. And it's a vital bridge back to your actual real lives, because a lot of what we do in the clinic, it's very medicalized in terms of actually living with the illness. They are a vital support. And I know many of you would know that already, but I think it's for those of you who are new, but also for those of you that may know other people or come across people, do please help us in spreading the word about rare dementia support.
I just wanted to add to that as well. Nikki made such a valid point about the postcode lottery that I know so many of you will have already experienced. And I think that's also something that I've found is that people have said to me, by then talking to Nikki's team, it's helped them think outside the box. Because of course there are some areas where there may not be, let's take, for example, a local speech therapist. Unfortunately, for whatever reason, then there may be nobody in the position. The service we know there's a shortage across the country. We're 20% of all speech therapists in short supply. We need a further 20% to actually fill current positions, but also some services aren't commissioned. But so taking speech therapy as an example, Nikki and her team can help you think outside the box. So there might be other ways or other services, or even just brainstorming some ideas with the rare dementia support team, or even with me via email, who the rare dementia support team can always put you in touch with me. And there are some other charitable sectors, and there are even some therapeutic research projects that Nikki and the team might even be able to put you in touch with, so that there is something to access in some way or fashion.
Brilliant, thank you all. So let's cross to our first live question, which is very exciting. This question says, my husband has been diagnosed with probable FTD symptoms or logopenic variant aphasia, progressive aphasia. Unfortunately, dementia services are poor here, so it may fall to his GP to prescribe any medications needed in the future. I've heard that some medications are suitable for some types of FTD or PPA, but not for others. Are there any medications, common medications, that we should avoid for logopenic variant PPA? And Jason, I'll ask you to come in on that one.
Yeah, thanks. Yes. Well, yeah, this gets to a very important point. So yes, that's true. So logopenic aphasia, in most times it is very confusing, because we sort of talk about PPA in terms of frontotemporal dementia, but actually in most cases logopenic aphasia is a rare form of presentation of Alzheimer's and has that pathology in the brain. And many of the same issues that people without, more typical forms of Alzheimer's have will develop later as the disease goes along. So this is, again, a reason why it's very important. We always say to have follow-up, medical follow-up, because people need to be alert to these things and help to anticipate these things. So medications, it really speaks to that, because we don't really have good medications, even symptom medications, for treating most frontotemporal dementias. We do use certain tablets for them, but the most standard of the tablets that we have available are the symptomatic tablets for Alzheimer's. So these are the ones, and there's a small number of them which have been around for several decades, really. Donepezil, rivastigmine, galantamine, and memantine. They're cholinesterase inhibitors, they're also called sometimes. Memantine is a different type of tablet. And they're the standard symptomatic tablets for Alzheimer's, by which I mean they're the tablets that people use to try and bolster memory and other brain functions. Chris's work and others have shown that they probably do have a benefit for speech and language processing, but that's not that widely recognized by doctors. So in terms of the process, for a start, and this is why hopefully a memory clinic will have a role here, the GP may need to be kind of advised that this is actually a form of Alzheimer's, and so is eligible and should be considered for these tablets, because they may not be thinking in terms of that. I mean, it's a speech problem, not the typical way Alzheimer's comes to light. But it's important to think about these tablets the same way we would for anybody with other forms of Alzheimer's. They're very safe. About the only main precaution is with some types of heart conduction problems, irregular heartbeats, which is why sometimes we need to do an ECG, and we also need to make sure that someone's heart rate's not going very low. But apart from that, there really aren't many reasons not to give them a try. They usually don't have that many side effects. They do sometimes give people an upset tummy or can make people a bit restless. There's some side effects. You'll see there'll be some listed if people have them prescribed, like any tablet. But by and large, they're pretty easy tablets to use. Unfortunately, they don't work that well, so they're modest benefit. So, we say it varies from person to person, and sometimes people don't really notice that much benefit, but we usually try to get people with logopenic aphasia onto the tablets, and usually a combination of one of these cholinesterase inhibitor tablets, say donepezil, for example, plus memantine. We usually use the combination so that someone's getting maximum treatment. Now, if you have one of the other forms of frontotemporal dementia, PPA, there isn't that kind of option. We do sometimes use tablets, though, to treat other issues that arise, and they're not really treating the primary process, but they're treating other types of problems. So, for example, someone might get quite depressed, frustrated, depressed, anxious. We can give medications for that, and that goes for all types of PPA. Someone might get very agitated, for example, or have behavioral change. We can give tablets for that, but then again, they need to be used very carefully. And seizures we've talked about, and that needs its own tablets, the anti-epilepsy, anticonvulsant tablets, so they're separate again. So you can have people on tablets for PPA and combinations of tablets. The new drugs that are being used for that are very much in the news at the moment for Alzheimer's, the immune type mediating drugs, of which lecanemab is probably the best known, donanemab. They are not really being used widely. They've just become licensed, but there's still major issues around how they will be prescribed and supplied. But potentially, people with logopenic aphasia, because it's an Alzheimer variant in most cases, if they've got Alzheimer type markers, may be eligible for that too. So that's something to think about mainly for the future, I guess. Watch this space. And the question was asking about tablets that are to be avoided. And yes, there are some. So, for example, if you're on one of these Alzheimer medications, other drugs that might slow your heart rate down further would need to be watched quite carefully. And in general, for anybody with PPA, we're very wary about drugs that are going to make someone very sedated or potentially give them movement related side effects, a bit like Parkinson's type side effects. And the main category of drugs that are potentially doing that are what used to be called the major tranquilizers, or we call them neuroleptic medication. And there are various generations of these, but they need to be used very carefully, if at all, and under supervision. And sometimes they are necessary for someone who's getting very agitated or very distressed, but they need to be used carefully. So those tablets do need to be avoided if possible and used very carefully. And the same goes for any tablet that acts on cognitive function. So, for example, some types of antidepressants, some types of anticonvulsants, etc., can be particularly difficult to use in someone who has cognitive impairment. So it is a neurologist type zone, that kind of level, unfortunately. And I think if you're alert to this, the right way to sort of to manage things, if you're a caregiver or a person living with PPA, is to be alert to any new tablets and query them with the GP. And no doctor should ever object if you say, well, hang on, is that tablet going to be a problem for me or for my loved one? And that's the way to manage it, and ask advice if not sure.
Thanks, Jason. Yes, Anna?
I was just going to mention at the beginning of the question, the person had said that they felt their local services were a bit poor, and in relation to dementia. And in my experience, some people like to or are able to access support from services nationally at Queen Square by requesting a referral to Professor Warren. Who can then
one of my senior colleagues,
or one of the team who can then provide this expert advice. So I just thought that might be a useful point to make.
And the other point there is that they're very important. We don't get too fixed on tablets, because they're actually the most important aspects of managing the PPA and living with it well are not tablets. So we hope the day will dawn and we can put someone on a tablet that fixes the problem, but we're not there. And so at the moment, it's much more important in a way to be thinking about support. We talked about rare dementia support, but also ANA and speech and language therapy are, I'd say, as a neurologist, far more important than tablets.
Great, thank you. So next question is, again, I think one for you probably, Nikki. any advice on organising support and help when the person with PPA is very reluctant to accept help, but it is obvious that help on a daily basis is required?
Thank you. What a good question, and something that comes up very, very often, as I'm sure Anna and Jason are very aware of this as well. So I think what's really important is to think about where best the support is needed, and realise also that people have, you know, a diagnosis of PPA, so they're not going to be functioning 100% like they used to, and sort of, you know, to sort of manage expectations of yourself as well with that. I think it's really important to encourage sort of empowerment and choice by people. I think, you know, and using sort of positive language to sort of approach the subject of what support is actually needed, not sort of telling people they need this support in place. And think about what the support's going to be beneficial for. Is it going to be beneficial for that person living with PPA, or is it going to be beneficial for the family and carer member as well? Because we don't want people to burn out. So I think what I'd always sort of do is do a list of what the activities the person can still do really well, focusing on the strengths first of all, and then where they need their assistance as well, and sort of looking about what sort of that assistance could be. It might be friends coming to help, coming to encourage, and often there's sort of people say to me, oh, friends always offer to do things, but I'm sure they don't mean it. So, you know, I would answer that with always have 3 things in your back pocket. If anybody ever says, you know, if you need anything, so yeah, actually, can you come round Monday night, take him to watch a game of football? Can you come round on Thursday afternoon to go for coffee? And can you come round on Friday to help do some shopping? So you've got some sort of varieties that friends can come in to help. If somebody really does have some needs that they need some sort of more intensive help, I think it's really important of bringing things in slowly into the home, introducing care through a personal assistant. The title personal assistant is so much more empowering than having, you know, a carer. And I'd quite love a personal assistant, to be quite honest. I'd be very much open to that, to people coming to help with sort of daily tasks and things. So I think sort of introducing a personal assistant and having somebody come in slowly and just having a cup of tea and bringing some chocolate cake along is always a big winner before you start bringing tasks into a routine. So hopefully that will help with sort of encouraging sort of some empowerment and some control for the person as well.
Great, thank you very much, Nikki. So moving on, we were talking about one type of tablet earlier, thinking about a different kind now. So this person asks about digital technology and AI, which are rushing ahead, but they don't hear much about research to link the problems of people with rare dementia and progressive aphasia to these developments. There are so many apps, for instance, that can give a voice to people with advanced progressive non-fluent aphasia or non-fluent agrammatic variant PPA. Are there any that we would recommend? So Anna, I might come to you first on that very specific point about apps for non-fluent variant PPA to help with, I guess, speech production. And then Jason and Nikki, if you've got any general comments about apps and digital technologies that people might find helpful, I'll come to you. But first, Anna, what are your thoughts about that?
Thank you for inviting me to respond to this question. And absolutely, the person who's asked this question has made a really valid point. There are heaps of apps, and lots of people find them really useful and lots of people don't. What I will say is regarding voice synthesizing apps, sometimes called voice banking, this is a very particular type of technology where people, the most technical type being where you can record your voice through some software and it gets saved. So you bank it. It's like investing your voice. You have to have a relatively fluent voice. The technology, it still requires your voice to be quite fluent. And then if you want to use that voice, you have to spend several £1,000s to draw down that voice. That then gets that can be used via another app that you would have in an iPhone or a tablet device, and then you have to. But the voice synthesizer cannot read your mind, you then still have to be able to generate words and sentences and select what you're going to say. Now, to be absolutely honest, I have only met I can count on one hand the number of people who've found this technology to be useful. I'm very careful about using that particular technology. There are lots and lots of other ways of using apps and even of voice banking. So, for example, I tend to find, and I know from the research we've done, that people actually are more likely to find apps that they already use useful. So, for example, if you're somebody who already uses some apps on your phone, like videos and photos, and the files on your phone, the fact is that's much easier cognitively to be able to use them. So we can leverage those apps, record videos of you or audio files of you, or create files on your phone using the apps you're used to using. That's it. And the evidence shows that in terms of behavior, all of us are much more likely to use apps we're already using. So we can tweak apps you already use much more effectively than introducing new apps. I would say there's also a grey area in between where there are some other apps that can help you practice. So, for example, there are some apps, if you're somebody who's decided to do practice of words or sentences, which is not everybody's cup of tea, there are some apps that can be useful, but again, they have to be purchased and they require a bit of time investment. And there are also a couple of apps that work quite well that can help you if you are somebody who later on down the line is able to and interested to navigate apps to show people what you mean. There are some, but they need to be carefully chosen to meet your needs. I'm trying to warn people that I genuinely think that choosing the right apps that suit you, both for your speech and language needs and for where you are on your disease journey and for what works for you, should be done by a team of professionals and experts in the area of PPA. So sometimes that might be members of RDS making suggestions, or occupational therapists, or speech therapists, or psychologists, or medics. And that needs to be carefully done. But I'd say if I had to name one app that I've had the most success with, it's the photo app on someone's phone. It's a really fantastic resource. We all use it, and it can really give context to conversation and interaction.
Brilliant. Thanks, Anna. And Jason and Nikki, would you like to come in on that one, or shall we move on?
I can just endorse some of that. I mean, I think as a neurologist, it is difficult, isn't it? Because you would think, and I think actually a number of sort of people in the profession, medical profession, also have this sort of view that what's wrong in PPA, people's ability to talk, is often how it's seen. Well, we'll give them something that helps them talk, and then we get into discussions about the synthetic voices and so on. But I think it's really important, what Anna said, to sort of bear in mind that that's really providing you with a voice box. The problem with PPA is in the brain. It's rarely useful. So it's much more useful. I mean, they were developed for things for people who've had laryngectomies and motor neurone and things where it's really mainly in the muscle problems. So it won't be useful. Occasionally, for most people with PPA, occasionally it may be useful for people with very extreme forms of one subtype of non-fluent, where it's mainly around the muscle control output side. But that's a very, very small number of people. And actually, even for those people, and it's what Anna was saying, I think it's really important to be able to think laterally, or be able to be helped to think laterally. So, for example, I've seen much more in my clinic, much more success with things like light writers and people using digital tools, because initially, it's often the control of hand gestures and so on is much better than the control of speech. And then they can, and particularly if they are using devices where a bit of repair can go on with things like spelling and grammar, that's much more useful. Again, mainly for people though with non-fluent PPA. The people with semantic variant and logopedic variant, it is actually unfortunately much more difficult. but even there, it's what sort of Anna said, that you need to be able to sort of think also about, more broadly. So, for example, and Chris's research work is looking at this as well. We know, for example, that PPA is not just about talking; it's also about receiving signals coming in, hearing, listening signals, communication, the input side, if you like. And then things like, all the digital technologies we use all the time, for example, this one today, can be a big problem for people with PPA. So we'll be very interested in your feedback about that and many other things from today, but actually the use of video technology and so on, there are platforms and things there was a lot of interest in trying to help improve these, so that the communication input side is as good as possible. And that also goes, of course, for non-digital things in daily life, but it's I think one of the dimensions of the question is the research side, and there's a lot of interest, as there is with other forms of dementia, in gathering lots of information about how people use devices and other things in the real world, how they use their phone, how they use their laptops. And that's, not without controversy, because you're in a sense of monitoring what people are doing a lot, but there is potentially great power in building up like a signature of how someone interacts with their technology in the hope of improving it and facilitating it. And that is a very active limb of research, but mainly now, at the moment for Alzheimer's, as it is for so much in dementia. But increasingly, people are starting to think about other diseases like the frontotemporal dementias as well. So I think it's very much watch this space, but very important to make it personalized to you, make it actually useful to you, and discuss it with your medical team. I think that the brain training side of digital apps, of which there are a number around, brain rehab, brain training, in general, are not very useful for PPA. And if there's interest, well, we can perhaps follow up on that. But for the sake of time, I'll hand over. Nikki, do you have any comments?
No, not really, but just I love the photo. The photo is the best thing on the phone, as Anna says. It's, photo time, and sit down later in the day to go through the photos with a glass of wine or a cup of coffee is wonderful. Best tip ever.
Great, thank you. Jason, just a quick point of clarification. What was the name of the medication that is commonly combined with donepezil? Is that memantine?
It's sometimes called, yes, sometimes called Ibixa. It's a sort of trade name. Yeah.
Okay, perfect. So we've had two questions in actually about pain in different forms of PPA. So one person's written that something that causes her mum with logopenic variant PPA to have difficulties with her sleep is pain in her back, and she also touches her face during the night. And paracetamol seems to help this lady. There's another person who's emailed saying that their husband has semantic variant PPA, and he often appears in discomfort, frequently rubbing his hands and his legs. Bizarrely, though, he had a nasty tooth abscess in which he didn't feel any pain at all upon its extraction. So both people have asked about if it's reasonable to give paracetamol to help with this pain, and also whether or not a mild sleeping tablet would be appropriate, or if this might cause grogginess and other problems during the day. So, Jason, I'll hand that one over to you if that's okay.
Yeah, this is really important and not very well recognised. Actually, often we tend to get a bit lost with other priorities in PPA, but it is really important to be alert to it, and it is not uncommon for people to get changes in both their pain perception and awareness, and also in their sleep, and the two can interact. And this is a major issue that needs to be much better recognised. So it's complicated, as with everything with PPA, and to some extent because there are the different forms and they behave in different ways, and that's linked to the areas of the brain that they mainly affect. But for example, we know that, and we've studied this at a research level too, and sort of published some work on it, that people with semantic variant can have major shifts in their sensitivity to pain, and it can be in either direction, or as that question is implying, these quite complicated combinations where people can be apparently very bothered by what might be regarded as fairly anodyne things, and yet may totally, seem to ignore conditions that we might expect will be very painful, like the tooth abscess. So it's very difficult to understand that. But I think one way to think about it is that that in that condition, you kind of have, we know people with semantic variant will know about this, those living with them, that the understanding of signals is a problem, and that of course is initially speech and written communication, language signals, but it also goes into lots of other types of signals, and it includes your own bodily signals. And there's a kind of a problem with dealing with the information that's coming in. And if you think about it in those terms, you can sort of think, well, actually, you can begin to see why people might have these quite major changes in how they react to pain, because they don't quite fathom, they can't fathom, what the significance of that sort of ache in their leg might be, or that discomfort versus the pain that they might be getting, and how to deal with that. So there's a major disconnect. So that's that condition. But it is also true that in the other conditions, it can be forms of PPA, it can be affected. And again, a bit unpredictably in the individual case. But it's very important to remain alert to it, because people can express pain in different ways. And the most obvious thing, I guess, to say is that if someone can't tell you, you may need to begin to be more alert to their non-verbal signals, the wincing, grimacing, the problems with the sleeping, etc. And the first priority always, if someone's in pain in medicine, is to work out why, because sometimes it's something that really does need to be treated, like a broken bone or something that's gone undetected. And so very important that the GP checks that out initially. But sometimes, of course, it's not, there is no obvious cause. And then we focus on management. And as the questions were implying, this is also challenging, and we don't want to give people major painkillers that might lead, for example, to sedation, might lead to problems with addiction, etc. And so it's very important with all forms of pain management in medicine to tailor, it's like a kind of a bespoke approach where you start and go through tablets or medications systematically. Paracetamol is a good one because it's relatively innocuous. You need to have to be very careful not to take too much of it. There's clear guidance about that. But within the sort of the recommended usage, it's pretty innocuous and can be given regularly to kind of keep control over sort of low level pains. Of course, it's not so good for more severe pain, and it's also not particularly good for pain where there's a big component of the brain's reaction to how they're interpreting. So, for example, if the pain is trivial, but somewhat apparently trivial, but someone is very distressed by it, as far as they're concerned, that's a significant pain, and paracetamol may not always be useful in terms of that reaction. So there, we go for things like antidepressants. We don't use them primarily for their antidepressant properties. We use them because they act on neurochemical pathways in the brain that also are very important for pain perception. So, for example, there's serotonin blockers, which get used as antidepressants. We sometimes use, there's one called mirtazapine, which can be used to provide a bit of sedation at nighttime and also modulate pain pathways for people that are having major reactions to pain and distress where there's no obvious cause found. So it's complicated. You always need to look for a cause and think about a structured approach to kind of analgesia, but also beyond painkillers, analgesics, these other dimensions to the pain are very important. And that goes for all forms of PPA.
Thanks, Jason. So the next question is about sort of progression of PPA. This person says, having had PPA for 3.5 years, I've noticed a gradual decline. What are the stages and timelines of decline? How will I be monitored? What about swallowing? I've been asked at various times if this, i.e. the swallowing, is an issue. So I might just start by talking very briefly about the progression, the stages, so to speak. So this is a major piece of work that we tried to do very recently with members of the primary progressive aphasia support group, because people very reasonably kept asking the same question: what will happen to me next? So we surveyed several hundred people with PPA, or the caregivers of people with PPA, to ask about the symptoms that they might experience and the order in which they might experience them. We have now published those, and this is a sort of a multi-centre international study with a group in Australia as well. Published those in 2 academic journals, and we're working hard to get them onto the RDS website as well, which is being sort of revamped at the moment. So we're hoping that those will be up there shortly. So having said that, we've done this piece of work, I do want to caveat it though by saying that actually some of the questions that are associated with that, so asking specifically about the timelines and the durations of the different stages, we found that was actually too difficult to answer. There was too much variability across people for us to be able to be confident in putting sort of any numbers to those really. And in general, the best predictor of sort of the rate of progression seems to be the rate of progression up until that point. So if it's been in general a very slow rate of progression, it seemed to be the case that would continue as well. Just to tie into the last question a little bit as well, so the person who asked about this pain in semantic variant PPA, really interestingly, that, for example, it was one of the many symptoms that was identified by caregivers of people with semantic variant PPA, so complaining of pains or bodily symptoms without any apparent cause. Just as an example, that was put into stage 3 of those stages, and it was a tremendously helpful, informative exercise that would not have been possible without many of you watching this today. So just thank you very much for all your help with it. So now to this to the more specifics of this question, particularly about swallowing. So Anna, can I come to you to ask about how swallowing is assessed and monitored and tracked in PPA?
Yes, of course. So it's the role of the speech and language therapist to help people manage their swallowing. So what typically happens is that people might mention they are having difficulties. So we'd be looking out for, and the doctors and all the staff involved on the team might be looking out for signs like a person coughing more frequently on food and drink, people experiencing food going down the wrong way, perhaps discomfort when eating and drinking, or weight loss and chest infections. And the reason I mention those 2 last is because we may look out for those things, but also they're the things that we want to avoid happening. So we want to reduce the risk of you losing weight or reduce the risk of you getting chest infections. And they're the things that can happen if swallowing becomes difficult, is that there is an increased risk of weight loss and chest infections. And of course, a loss of pleasure in eating and drinking. So the role of a speech therapist would be then to assess what's happening, whether that, at what point the difficulty is. So we assess all the movements of your lip and tongue and mouth and the swallow reflex, the timing, the range of movement. And we can offer lots of ideas to and solutions to reduce the risk of things going down the wrong way, and increase the risk of it going down or chance of it going down the right way. And so we do that by making recommendations around sometimes modifying the types of food, avoiding types of food. And it's very dependent on the person and the problems the person's having. Sometimes, very occasionally, we might make recommendations about modifying the thickness of drinks. We try and avoid that. And we might even make recommendations about strategies about how to eat and drink. But that is the thing we're concerned about, is the increased risk of those 3 things around pleasure, chest infections, and any weight loss. We tend to see that lots and lots of people who have non-fluent primary progressive aphasia, we tend to find people who have non-fluent are more at risk of swallowing difficulties earlier in their journey. Whereas we do see swallowing difficulties happening sometimes for people with semantic variant PPA and logopenic PPA, but we're more conscious of this happening somewhat earlier for people with non-fluent. So that's probably as much as I can say about staging and timeline, is that just happens a bit earlier for people with non-fluent, we think.
Brilliant.
Can I
Thank
just
you,
add,
Anna. Yes, Jason,
to that so both Chris mentioned some work he'd done, led on, well, you all had done really in a way, but Chris got brought together, and Anna has just published a major paper on swallowing in PPA. Now, both these papers are in the public domain, so we don't want to bamboozle people, but if you're interested, we can certainly make them available to you if you let us know. But one of the things that both of those things underline, both those pieces of work, was the importance of swallowing and the stages at which it begins to develop, which is usually a bit later, but in the non-fluent case can be a bit earlier. So we do need to, the diagnosis is very important. And within that, Dana identified some predictors. So if you've got a diagnosis of non-fluent, we need to be careful. And within that, if you've got problems with your control of your facial movements, which the neurologist can assess, or Parkinson's type features, they are risk factors. And the other thing for asking about swallowing, or thinking about swallowing, and the other thing is the overall severity of someone's cognitive dysfunction. So if someone is really going down, losing function, swallowing, unfortunately, can also be part of that. And so it's very important that it's asked about. And if it's not asked about by the doctor that you're seeing, you should feel empowered to raise it. And as Anna rightly says, the way to assess it is to have a speech and language therapist help us actually measure it and assess it, because really the key thing here is safety about swallowing. And there are some techniques that can be used to help someone swallow as well.
And I should mention, you've just reminded me, Jason, we haven't actually mentioned dietitians. So it's often very important for us to refer you to a dietitian to advise on nutrition as well, around to reduce the risk of weight loss, just to mention that.
Great, thank you. So moving on to the next question. This person's written in the Q&A section, hi, my husband has a progranulin mutation presenting as PPA. He no longer understands words and has no speech. However, he laughs and shouts very loudly what sounds like an elongated yes. This behavior scares children, startles unsuspecting people, and makes going anywhere public very challenging. And I too struggle with this loudness at home. Is this common, and is it likely to persist? So Jason, I'll come to you for that one.
Yeah, I mean, this is noise making of different kinds can be a major issue. It really wears people down, that people living with that. I think the honest answer is we don't know exactly how common it is, but it's not uncommon, and it may be more common in some types of PPA. Very unusual forms of laughing, which are not really mirthful laughing. In non-fluent, we do see progranulin is often in that spectrum. And progranulin mutations, unfortunately, it's a very complicated illness. It also affects behavioral functions often, so that can interact with it. It's difficult to treat, is the honest answer. It's often better treated by sort of environmental management, and of course that can be hard. But for example, people that are in care can be given, sort of a slightly more discreet place where it's less intrusive for other people. And to some extent, how people caring for them think about it, because often it's not a hallmark of distress. I mean, we need to be careful and be alert to as we talked about, nonverbal cues. Sometimes people use this as a way of expressing distress, but often it won't be that. It will be apparently random for no reason that anyone can discern. Maybe it's an attempt to communicate, but often it doesn't seem to be. And if the person's not getting distressed by it, then the question always has to be asked, what are we treating? I mean, are we treating the distress of those around them? And of course that can be significant, but I think it's important to kind of get a clear sense of that, because excuse me, the tablets that would suppress that kind of behavior, the shouting and the intrusive vocalizations, unfortunately do tend to make people sedated. There are not many very specific tablets that we've identified that act on noise making. So what tends to happen in our clinics is a bit of trial and error. We often give people the kind of tablets we use for other types of challenging behavior. The new generation, the serotonin blocking antidepressants and tablets in that line. We try to avoid the major tranquilizers for the reasons that we've talked about, because people can be very sensitive to bad side effects from those. So I'm afraid to say it's a difficult problem, not that uncommon. And to some extent, it needs a medical team committed to being able to work through with you some different, on a trial and error basis, different strategies for managing it.
Thank you, Jason. And Nikki or Anna, I don't know if you had anything to add specifically about, strategies to manage being out in public. And yeah, Nikki, do you want to come on that?
Thanks, Chris. Yeah, just I would like to add is, if possible, always wear a sunflower lanyard to show a hidden disability. Explain to people in advance that this may happen. And when I say explain to people, just explain. You don't need to apologize. This is a symptom of the disease, and there's lots of people in life that have different other diseases which causes embarrassing noises and things. So please just explain that, this is a symptom of the disease and this may happen, and prepare people in advance if possible, and probably try to choose times to go to certain places when it might be a little bit quieter as well, especially if children are around.
I'm so glad you mentioned the lanyards, Nikki. And some people say that the person with PPA doesn't like wearing a lanyard. And I know that some people that Nikki and I've worked with, often the partner's then chosen to wear the lanyard, so that actually it's you as a family unit are showing and conveying that information. And you can actually put on the lanyard some information about how to communicate with me, or explain some of those communication behaviors. And I would say that as Nikki flagged, this is a symptom of the disease, but it is a form of as a speech therapist, we also talk about all behaviors as a form of communication. So it's also worth explaining, that helping people interpret it, because it's often people say to me, they feel uncomfortable because it's not something we see or hear usually. So actually saying to people, this is a form of communication and this is what you can do. So for example, you could say, and what you could do is just put your hand on his hand, or what you could do is just agree and say yes, or what you can do. So you're telling people how to deal with it, because that's often what people are worried about. They say, what should I do in response? So instructing people what to do in response is very useful and very practical.
Great, thank you all. Next question. I have been diagnosed with PPA and I have some visual hallucinations, some of which are quite realistic. And does this matter? Jason?
Thank you. Yeah, yes. I mean, we don't see that as a common problem. It can sometimes happen. It depends really how distressing and how much of an issue they are for you. I mean, there are people who manage to live fairly successfully with sort of occasional visual hallucinations that they recognize aren't real things. And it depends what the hallucination is, of course, and some can be more distressing than others. Often people, and I'm generalizing, of course, don't know the individual case here, but often people will see people or more benign types of animals, so cats and foxes and that kind of animal. And they may see them in particular places in the garden and so on. And sometimes it can be a marker for a particular brain disease called Lewy body disease. But I would just stress that needs a neurologist to talk to you about the individual case and look for those features. And sometimes that can interact with PPA. But you can get visual hallucinations in other scenarios. You can get it in Alzheimer's, for example. So without knowing the individual background, of course, I can't comment on that. But it is a relatively unusual problem in PPA, but certainly not unheard of. And the way it's managed depends on the individual person, really. And sometimes some of the tablets in the Alzheimer type situation that are used, those symptomatic tablets we mentioned earlier, donepezil, rivastigmine, can help suppress hallucinations if they're more distressing, and particularly if they're coming on at predictable times. Often it's in the night time, or when the illumination is going down, for example, as a generalization.
Great, thank you, Jason. So Another couple of questions. I'm conscious that we're getting near to the end of our time. Just to reassure you that if you have submitted questions in advance or in the Q&A box that we haven't got to yet, we will get answers to those and send them out via email. We really appreciate people who've taken the time to join us today, and we know that it can take a lot of courage to ask for help. So we're grateful to you all, and we'll be committed to getting responses to those. In the meantime, though, we've got time for a couple more live, so to speak. There's this one, which I think is probably relevant to quite a few people. So is it common that people with PPA electively stop using verbal communication? This has begun to happen, and it's difficult to figure out whether this is truly elective or if their ability to use speech really has deteriorated this much. Anna, I'll come to you first on that one.
I would suggest that people don't choose to have any symptoms of PPA, and this is a symptom of the disease. So no, this person isn't electing to not communicate. What we do see is if people find communication difficult, it's harder to do, then of course people will communicate less, because people say to me, for many people it's really effortful to articulate if they have non-fluent PPA. For people with all types of PPA, they might find it hard to keep up with a group conversation, for example, because they can't follow or can't keep up, or they don't understand the topic. So it might be then you can't contribute because you're a bit lost. You can't hear what everybody said. Perhaps if there's there's background noise. So then of course it's harder to contribute to a conversation. And that's without touching upon the fact that people might have not only speech and language symptoms, but also we often see, and I'm going to use the word apathy, that's the technical term to describe what we consider a thinking or cognitive difficulty that we see across these types of PPA, often particularly in non-fluent and sometimes in semantic. But that's not the person choosing not to respond. That's actually it then becomes really difficult for people, in particular, to get started almost. That's how people often interpret that it's so hard for the person when you have apathy to actually go to start. So then they actually might not be able to get going. Often people say to us, and we know this, so we recently undertook a study across 20 countries around the world with nearly 100 people with PPA. And all those people said that for them, being able to connect with family and friends is the most important thing for them. So I can absolutely guarantee that people all with PPA unanimously want to connect and have relationships. They just might find it really hard because of speech, language, be it expressive or understanding difficulties or hearing difficulties, and thinking skills. They might all be so difficult that they can't get through those. And then, of course, if you're worried or anxious or embarrassed, that's a whole nother layer.
That's brilliant. Thank you, Anna. And I just want to squeeze in one last question. I think this one's probably for you, Nikki. And I think this will be relevant to several people. How do I find a care home for my wife with PPA that will understand about her specific needs?
Great question. And yes, we often get asked about care homes. And I think the answer is finding a care home or finding a home that's going to suit that individual. It's, when we all look at choosing homes, some people want to live in the middle of a city in a high-rise flat, and some people want to live in a country in a thatched cottage. It's the environment about it. So I would look at care homes which are going to have an environment that suits your loved one, hopefully not too far away from you, so you could visit if possible, but that might not be achievable. There's various different websites. There's a fantastic website called Lottie, which you can put in details and do a search for care homes. And we wouldn't anticipate that the care home staff will be experts in PPA. But if they're willing to learn, then we can help skill them up. And you know, we do care home talks. A lot of the times we talk to the care home staff. We have our RDS champions, who are people with lived experience, that go and talk to the staff and say, look, you know, this happened with my loved one when they went into a care home, and these are strategies which can help. So I think it's a variety of things to think about, and most important, it's the feeling of the care home. If you feel you can work with this care home, if they're open to learn, and you can have a good relationship to build a good care plan within that care home, that's much more important than anticipating or expecting them to be experts in PPA, because those are things that we can help teach. Anna, do you want to add with that? Because I know you've done some work within care homes as well.
Thank you, Nikki. I think you've covered everything. I think you're absolutely right. It's a very personal decision. And RDS and the multidisciplinary team often, as you say, Nikki, we often speak to care homes and provide advice. And Professor Warren and I have had clinic meetings with staff from care homes. So it's definitely something we can do. We can really support where we're able to. We can always support care homes. It's a very individual decision. Thank you, Nikki.
Indeed, and yes, thank you all. So I think that brings us to the end of our time. Jason, did you want to have any closing remarks?
I need to say, first of all, thank you to you, Chris, for doing that, all of the question mastering. Education is really important. That very last point is a good segue. You are all the kind of evangelists to go out and help doctors and others understand this, and hopefully eventually the general public, PPA. And in that spirit of education, can I just please urge you all to give feedback? We want to hear what's going wrong, what's maybe hopefully working with these sorts of webinars and these sessions. Please do give feedback, and we will listen to that and try and act on it. And the last thing is really just to thank Nikki and her team again for the brilliant work they do, and to Anna and Chris, and hope to see you next year.